I am going to be talking about the importance of patient assessment when giving local anesthesia. Prior to administering local anesthesia, we must assess the patient and determine the relative risk for the patient. Local anesthesia is a drug, and all drugs exert actions on many parts of the body. Once we give an injection, we cannot get that local anesthesia back. So we need to make sure that we are doing a thorough, proper assessment for our patients and reviewing their medical history so we are less likely to have an allergic reaction or potential medical complication or medical emergency. We need to assess in general their pain and anxiety levels, their general physical condition, determine their ASA classification, whether the patient needs any medical consultations based on the medical history information that they gave us, because our ultimate goal is to prevent a medical emergency from happening. We need to select the proper dosage and the proper anesthetic. Do we want an amide? Do we want an ester? Do we want vasoconstrictor? Do we not? ASA 1, normal healthy patient. ASA 2, patient with mild to moderate systemic disease. ASA 3 is a patient with severe systemic disease that limits activity but is not incapacitating. We may have to do medical consults on the patients in ASA 3 category. Typically, we see most of our patients in ASA 1 or 2 category. ASA 4, the patient has severe systemic disease that limits activity and threatens life. We are not typically seeing patients in the ASA 4 category, but a dentist may see them and may need to perform more emergency type dental treatment for an ASA 4 patient. Heart disease are congestive heart failure, heart attack, high blood pressure, heart murmur, pacemaker, and angina, and heart operations. These all kind of have to be evaluated a little bit individually, because each patient is going to have different manifestations of heart disease. If we take a look at heart attack, for example, we should wait 6 months before we see a patient who's had a heart attack. For congestive heart failure, this condition could affect liver perfusion. So it could increase the half-life of amide local anesthetics, which is the time that the anesthetic is in the body. If the anesthetic stays in the body longer, then there could be toxic effects on the body. Patients could be less tolerant to stress. Their cardiac stroke volume is going to be higher, and they're going to get more blood to the brain. So that could lead to the potential for a local anesthesia overdose. So we want to limit epinephrine to the cardiac dose and use it judiciously, which means minimal amounts. The cardiac dose for epinephrine is 0.04 milligrams, which is about 2.2 cartridges. For a normal healthy adult, it's 0.2 milligrams. The cardiac dose is 0.04 milligrams, which is 2.2 cartridges. For a heart attack or heart surgery, we want to check to see when their heart attack was, because if it's within the last 6 months, then we don't want to do elective dental treatment. If there's any questions, we could do medical consults. And if it is just past that, we still may want to think about using the cardiac dose of epinephrine if it's past that 6-month date. For subacute bacterial endocarditis patients, so these are patients who need to be pre-medicated. The dental procedure itself will dictate whether the pre-medication is needed. Local anesthesia in itself does not require pre-medication, but if we were using a periodontal ligament jet injection, that injection, which is into the periodontal ligament around the tooth, that injection itself requires pre-medication for those patients who would normally have pre-medication. But usually the procedure that we're doing at that time as well would also warrant pre-medication. So you're not just doing it for your injection. And the conditions that require the prophylaxis, the subacute bacterial endocarditis prophylaxis, are valve replacement, certain congenital heart conditions, heart transplant, previous infective endocarditis. And we have total joint replacements within 2 years on this list, but the American Association of Orthopedics does not recommend pre-medication at all anymore. This is no longer on the list. The reason that I left it on the slide is there's still some discrepancies with the orthopedic surgeons, particularly in our area. We have a list in the clinic of the orthopedic surgeons in the area that still want their patients to be on pre-medication, even though the association does not require pre-medication. The doctors know the patient's comorbidities, the doctors know the specifics about the patient, and if they want the patient to be pre-medicated for dental treatment, then we have them write the prescription and pre-medicate their patients if that's what they would like to do. There could be other kind of different strange conditions that require physician consult and may require the pre-medication as well, but those are a little more on an individual basis. Blood pressure, we need to record the blood pressure before and after we do local anesthesia. And we want to watch those higher blood pressures. Remember, we have new guidelines for blood pressures as of fall of 2018. Patients that are ASA3s, we need to watch and possibly limit the amount of vasoconstrictor that we use. Vasoconstrictors directly stimulate the heart and can lead to a decrease in cardiac efficiency. So when there's pain, the body itself responds to pain with an endogenous, so from within, release of epinephrine. That can be up to 40 times the normal amount that we would give in an injection. So if we give an injection and we have epinephrine in that injection, then we can control the patient's pain and hopefully control that large endogenous release of epinephrine that could be over the limit, which could tax their heart and decrease the efficiency of their heart. Heart conditions need to be evaluated individually because we would determine whether a vasoconstrictor would need to be used and how much anesthetic could be safely administered. Generally, when in doubt, we would use the cardiac dose, the 0.04 milligrams, which is 2.2 cartridges. With a stroke, same as heart attack, no elective treatment within 6 months. We would monitor the blood pressure and we would limit the use of vasoconstrictor. Patients with severe kidney disease or undergoing dialysis might not be able to excrete the anesthetics, and if they can't excrete them properly, they would stay in the body longer and it could lead to a toxic reaction. Anybody who tells you that they have an allergy, we're not going to argue with them whether it is a true allergy or not. We're going to assume that they do, unless it's proven otherwise, and then we're going to proceed accordingly. Allergies are rare, but they exist more often to amides, or I should say they're rare with amides, but they exist more often due to the preservative, which is sodium bisulfite that is in an amide that has vasoconstrictor. So the vasoconstrictor itself has sodium bisulfite. And sodium bisulfite is added to the anesthetic with vasoconstrictor to prevent oxidation. So if an anesthetic has epinephrine, it will give it a longer shelf life, but it has sodium bisulfite in it. We want to watch sodium bisulfite with anybody that is an asthmatic or who has asthma, because 10% of asthmatics are allergic to bisulfites and a reaction could occur. If a patient has an allergy to wine or dried fruits, then no vasoconstrictor would be used and no articaine would be used. Articaine has bisulfites or sodium bisulfite in it, and vasoconstrictors have sodium bisulfite. Someone who says they're allergic to wine or dried fruits, it could be the bisulfite that they've used for the preservative in the wine or the dried fruits. Patients who have uncontrolled hyperthyroidism could have an exaggerated response to vasoconstrictors. If they have uncontrolled hyperthyroidism, it's an absolute contraindication. So we absolutely do not use a vasoconstrictor because that could cause a thyroid storm. Anybody who has arthritis or painful joints, they could be limited to opening or certain injections might be hard for them to get. So say the IA, the inferior alveolar, they have to open wide for us to go in the back of the mouth and go our 6 to 10 millimeters above the occlusal plane across the contralateral premolars. That could be difficult for them to stay open for the time needed and wide enough for us to get to where we need to get to. What if they're only sensitive in the lower anterior? We're going to do an IA to get to the midline. What if we just did a mental? As we massage it in, it turns into the incisive, which numbs the incisive branch of the inferior alveolar, which is premolar to midline. In a lot of cases, that could be enough for that patient to not be in pain or to not have the sensitivity or the reaction. And instead of doing the IA, we would do the mental, rub it in, diffuse to the incisive. So we can just do a different injection to get that area numb. Patients that have reduced liver function, somebody with hepatitis, somebody with alcoholism, they might not be able to metabolize the anesthetics properly, and it could lead to an overdose reaction. So our amides are metabolized in the liver. So biotransformation occurs for the amides in the liver, and that's lidocaine, bupivacaine, prilocaine, and bupivacaine. We may want to use articaine or septicaine, which is the amide that behaves more like an ester. And for that, it's metabolized 90% in the plasma versus 10% in the liver. So somebody who has decreased liver function would have an increased amount of anesthetic stay in the body and potentially have a toxic or an overdose reaction. So we would want to take a look at using the amide articaine that behaves like an ester. Behaves like an ester based on the place where it's biotransformed. Epilepsies or seizures. Stress could lead to a seizure. Stress of the dental appointment, stress of being in the dental chair, stress of anticipating pain. So use stress reduction protocol, and a lot of the times the use of local anesthetic, it's not contraindicated, and it can actually reduce stress and reduce the chance of the patient having a seizure. Patients taking different psychiatric medications, we want to be very mindful of the medications themselves. Tricyclic antidepressants potentiate the actions of epinephrine. So the effect that epinephrine would have is doubled. So we want to limit the use of epinephrine. It increases the cardiac action with levendorphin 5 to 10 times. So that's your bupivacaine, 1 to 20,000 has levendorphin or neocorbin in it. We do not want to use. That would be an absolute contraindication for the levendorphin. For monoamine oxidase inhibitors and benzodiazepines, these are used for major depression and OCD. We would want to limit the use of vasoconstrictors. For somebody who has bruising or clotting problems, we really want to watch technique. When it comes down to bruising and clotting, we want to watch technique and the vascularity of the areas. We want to watch the vascularity of the area. So for PSA, where the pterygoid plexus is located, we would want to use our landmarks and make sure that we're aspirating in the 3 different times and make sure we're at a 45-degree angle to the mid-sagittal plane, 45-degree angle to the occlusal plane, and make sure our technique is as good as it can be to avoid the pterygoid plexus and to avoid any intravascular injection. So aspiration is very important. Malignant hyperthermia is a condition where the body temperature is increased and it's potentially life-threatening. It's caused by general anesthesia. There was some thought that lidocaine and mepivacine had been administered along with other drugs where malignant hyperthermia occurred. So they thought that mepivacine and lidocaine were related. And they found that it was not the case, that it is more related to succinylcholine and halothane, which are used for general anesthesia. So we still want to look at those local anesthesia or local anesthetics of mepivacine and lidocaine as a relative contraindication and possibly do a med consult for this patient. Atypical plasma cholinesterase is a condition where there is an atypical form of this enzyme and they can't metabolize ester type anesthetics. So esters are contraindicated. Amides are the alternative. Benzocaine, which is topical, is an ester. Patients taking cholinesterase inhibitors, which are frequently prescribed for myasthenia gravis or glaucoma, should not be given ester derivatives or the amide articaine. Give lidocaine or mepivacine with no epi. Amides metabolized in the liver are okay, but not articaine. Articaine is the amide that behaves like the ester, and it is metabolized in the plasma, mostly in the plasma, 90% plasma, 10% liver. So we would want to avoid that. With glaucoma, we would limit the epinephrine because that will increase ocular pressure. Methemoglobenemia. This is the inability of blood to bind to oxygen. We want to avoid prilocaine, articaine, and acetaminophen, which is Tylenol. Substitute other amide anesthetics. Cimetidine, which is an acid reducer used for heartburn, and lidocaine, cimetidine competes with lidocaine for binding to the liver enzymes, and it could lead to an increase in the half-life of the local anesthesia and potentially overdose. With the non-select beta blockers, vasoconstrictors should be limited, and these are metoprolol, propanol, Inderal. They could cause a serious rise in blood pressure, so vasoconstrictors should be limited. Systemic complications. All anesthetics are drugs, so no drug ever exerts a single action, and the potential of the toxicity rests in the hands of the user. There are a lot of people on different drugs that you could have a reaction. Anytime we inject anesthetic, we can't get it back, so we have to be very mindful that we are injecting a drug. Overdose can result from the over-administration of it, and it's related to the blood level after. So we want to use minimum effective doses. Age, weight, other medications that are competing for the same excretion organs and metabolism organs can have an effect on local anesthesia, as well as gender, whether there's disease present or not, the genetics of a person, and the mental attitude. Remember, we talked in the very beginning of local anesthesia about people being hyporeactive or hyperreactive. Hyperreactive would have a low pain threshold. Hyporeactive, low reaction, would have a, did I say it right? Hyporeactive would have a high pain threshold. Hyperreactive would have a low pain threshold. Not sure if I said that right or not the first time. Age. Young, old, and sick have the most reactions. The functions of elimination and metabolism may not be as mature for a younger person, even though we're not going to give anesthetic on anyone under 18, and then they can greatly diminish in the elderly, and they can greatly be affected by anybody who is medically compromised. The larger the body weight, larger volume of drug can be tolerated. And any other medications that are competing with the binding, it is called concomitant. And that is when 2 or more drugs are given at the same time or on the same day, and they're competing for the same excretory organs and biotransformation areas. So other medications are competing and can affect the action of the local anesthesia or the vasoconstrictor. Presence of disease, the patient's overall health can contribute to how it's excreted and metabolized. So if somebody has liver or kidney disease and the anesthetic stays in the body longer, there could be potential reactions. Drug factors that can lead to overdose are vasoactivity of the drug, the concentration of the drug, the dose of the drug, the route of administration, the rate of injection. If you give an injection faster, then it's going to go into the body system faster and potentially lead to an overdose. The vascularity of a site. If a site is very vascular or you have an intravascular injection, then it is going to go right into the bloodstream and could lead to an overdose. Presence of vasoconstrictor. Vasoconstrictor is going to keep it in the area and constrict the blood vessels in that area so that it's not absorbed as quickly. Any concentrations of the anesthetic. So a 2% lidocaine is like 2 drops in the swimming pool versus a 4% articaine, which is 4 drops. So true drops is less than 4. So even the concentration. The more vasoactive a drug is, the faster the absorption into the cardiovascular system. Lidocaine is more vasodilating. So if we looked at lidocaine and mepivacaine with no vasoconstrictor, just the anesthetic itself, lidocaine has more vasodilating ability, so it's going to leave the area quicker than mepivacaine would. The greater the concentration, the greater the circulating blood volume. 2% lidocaine, 2 drops in the pool, is less concentrated than 4 drops in the pool, 4% articaine. Smallest dose that's clinically effective is what we want to use. Dental doses in general are very small. We do not want to administer intravascularly, so we really need to be mindful of our technique and where we're going and know where our landmarks are and what we're numbing. Topical can be dangerous if the drug is well absorbed through the mucous membrane. Tetracaine hydrochloride is the most potent topical anesthetic. It's very well absorbed. Our benzocaine, which is a 20% solution, is poorly absorbed. It goes through and gives great surface anesthesia for that first 2 or 3 millimeters of tissue, but it's pretty poorly absorbed. Unlikely to have a reaction. Rate of injection is very important. 15 seconds injection time for a dental cartridge will produce elevated blood levels. If you're slow, about 60 seconds on an IA injection, you're going to have a much lower blood level of anesthesia. The greater the vascularity of the site, the more rapid the absorption is into the cardiovascular system. So IA and PSA are a lot more vascular. You want to prevent intravascular injections, so you want to use aspirating syringes. You want to aspirate 3 times. If you use the larger needles, smaller numbers, remember, larger needle, you are going to be more likely to get a positive or negative aspiration. And you want to aspirate in at least 2 planes, 3 for the PSA, 3 for the IA, and then slowly inject when you have gotten negative aspirations. Adding a vasoconstrictor decreases the perfusion of the area and the rate of absorption. It keeps it in that area. Signs and symptoms of local anesthesia overdose are slurred speech, shivering, muscle twitching, tremors. Cardiovascular signs of local anesthetic toxicity are cardiac dysrhythmia and myocardial depression. This is just the local anesthetic itself. Some anesthetics have anti-seizure properties at low levels, but at toxic levels, the primary manifestation is the tonic-clonic seizure. So low levels, great, but when they have toxic levels, when epileptic patients have toxic levels in their blood, then it could lead to a tonic-clonic seizure. CNS depression, if blood levels continue to increase, it could lead to respiratory depression and finally respiratory arrest. Mild local anesthetic overdose, slow onset greater than 5 minutes. It's possible that there was a large dose or rapid absorption. Reassure patient, give them oxygen, monitor vital signs, and allow them to recover. Mild overdose, slower onset, greater than 15 minutes. Then you're looking at possible cause being biotransformation problem or renal dysfunction. So a liver problem, kidney problem. Reassure patient, administer oxygen, vital signs, seek medical assistance. A severe overdose, rapid onset, within 1 minute, possibly an intravascular injection. The patient could go unconscious and could have convulsions. You would put them in the Trendelenburg position or supine, protect the patient if convulsing, nothing in their mouth, move things out of the way, emergency medical attention, oxygen if able, and an anticonvulsant will typically be administered. Severe overdose, slower onset, 5 to 15 minutes, possible causes, too large a dose, rapid absorption, abnormal biotransformation or renal dysfunction, so kidney or liver function. Treatment is the same as for severe. Seek emergency medical attention. Luckily, we've got the hospital right next door. Epinephrine overdose is rare with most vasoconstrictors. It will often happen with a gingival retraction cord that is impregnated or has epinephrine in it. Now, the gingival retraction cord is packed around a tooth in preparation for a crown impression, and it pulls the tissue back. It controls bleeding, so hemostasis, and then it pulls the tissue back. And the epinephrine overdose is more common with that. Epinephrine overdose would be anxiety, headache, perspiration, dizziness. That's the heart palpitations that I talked about. The increased blood pressure and increased heart rate. The patient gets a little bit panicky because they feel that palpitation and increased blood pressure. Stop the procedure, reassure patient, sit them semi-upright, monitor their blood pressure, possibly administer oxygen, and allow them to recover. Allergies. Hives, itching, and swelling are typical allergic responses. Respiratory responses, a bronchial constriction, so constriction of breathing, or swelling of the throat, the laryngeal spasm, are more serious, more related to the anaphylaxis reaction that could lead to respiratory arrest and cardiac collapse. That is a lot more sensitive, or a lot more serious. Hypersensitivity to esters are common. Allergies to amides are rare. The PABA that was used as a preservative is what patients were allergic to with esters. Sodium bisulfite is what a patient may be sensitive to or allergic to in an amide, but it's related to the vasoconstrictor. It improves the shelf life of the vasoconstrictor. It's also used to keep fruit from browning and found in wines as a preservative. Topical anesthetics are esters, and they could potentially have an allergic reaction. So we need to watch benzocaine. If there's any doubt, allergy testing should be done, and we shouldn't use the esters or the benzocaine or whatever they've mentioned that they're allergic to until we have those allergy tests. Delayed skin reactions, Benadryl. If it's 60 minutes or more after we've given them the local anesthesia, then Benadryl and maybe a medical evaluation. If it develops within 60 minutes, then we would want to look at 0.3 milligrams of epinephrine intramuscularly or subcutaneously, and obtain a consultation from a medical specialist. May need to call 911, but fully evaluate before the next appointment, and of course before the next local anesthetic injection. If someone is having a hard time breathing, put them in a semi-erect position, administer oxygen, administer epinephrine, administer a bronchodilator, so our inhaler, call 911, and then for sure evaluate before their next appointment and before their next injection. Management of laryngeal edema, so swelling of the throat. Patient supine, call 911, administer epinephrine, administer O2, and maintain their airway. Anaphylaxis, position patient supine, call 911, give them epinephrine, give them oxygen and basic life support. Again, luckily we're right next door to the hospital, so it's going to be a quick reaction. Alternative to the use of local anesthetics in a dental emergency, analgesics, general anesthesia, histamine blockers. And this is alternatives to the use of local anesthetics would be any of these could be done for the procedure itself. So managing the pain with analgesics will sometimes be an alternative to local anesthesia. General anesthesia, patient wants to get put to sleep to get their dental work done. That's sometimes an option. Hypnosis or biofeedback are some different techniques that patients use to control pain. So if a patient becomes unconscious, then we should look at it possibly being syncope related, because syncope is the most common dental medical emergency. Place the patient supine, possibly the ammonia inhalant, administer oxygen, keep track of vital signs, and medical assistance if they do not come back momentarily. All right, thank you. Great job, guys.